Afternoon, everybody. My name's Catherine Redshaw. I'm a haematology specialist nurse at Salford Royal Hospital. My role works within oncology, so that's working with patients who have blood cancers, and it's a specialist role to help patients through their pathway. Now, I'm aware that you are all in year 12, so just starting out at the either apprenticeships or additional qualifications or A-levels. So could we go to the next slide, please? So I came into nursing as a mature student, so I left school and got a job as a bookkeeper. And when I was in my later years, I did some voluntary work at St Anne's Hospice in Little Hulton, and then I went back to college to do my A-levels in health and social care. From doing my A-levels, I went on to Salford University to do a nursing degree in adult nursing, and that's where it got me into being a registered general nurse in the hospital. And because of my exposure and experience of working in a hospice, my interest has always been around oncology and cancer. Next slide, please. Have we got stuck?
Has it not gone to the next one for you yet?
Yeah, it has now. Can you add me, Alison, please? Hannah, please.
Hold on.
So the current entry routes for this role for...
Oh, it's talking about, guys, it's talking about flipping entry routes and everything. Proper nurse talking.
You want to add mate Olivia? Okay, so the current entry routes for this role is what happens at your age is sometimes at your age you may not know what you want to do. So you do A-levels and a degree, and that maps out your pathway of where you may want to end up. So to be a registered nurse, you'll need your maths, English and science when you leave school in GCSEs. Then you would go on to do your A-levels or BTEC, or equivalent is an access course at the local college. And then you would go on to university to do a degree in adult nursing, children's nursing or mental health nursing. Next slide, please. So my career path, in my early years as a nurse, I was a registered general nurse within cancer, surgery, medical and oncology, and then I did chemotherapy, radiotherapy, and then I went into research nursing. And I had a special interest when I did research nursing in haematology, and that's where I am today. And I've been in this role for over 10 years. So I work obviously for Salford Royal as a specialist nurse, and I am part of, when patients get diagnosed with a blood cancer, I support the consultants and the team through their cancer pathway of having chemotherapy or radiotherapy. What do I enjoy about my job? One of the big things that I really enjoy about my job, whilst it's very difficult and can sometimes be very sad, it is also very rewarding, and we get to meet people, or a privilege to meet people that we may never meet, and support the patient and their families through a very difficult journey. The most challenging part of my role would probably be in the last 2 years, if you're all aware, and this has obviously affected most of your studies, and maybe we've all been touched by COVID in some different way. But this has been, in all of my career, this has been a very challenging time because we've had a lot more exposure. We've had to change the way we work. We've had to change the way we see patients. So we see patients differently now, how we used to be. And once you start your role as a nurse, if anybody wanted to go down the pathway of a nurse or healthcare, as in like a physio, an OT or anything like that, you start off doing shift work, but when you get to a specialist role, you only do days and you don't do any further weekends or nights. Because I don't know if you're all aware, but a medical role in a hospital is 24-hour care, so the care never stops for the patients. Next slide, please. Now, I don't know if any of you have done, I'm just going to do a little case study for you. If anybody has got any answers or any suggestions of what we may have done in this situation, just put your hand up or put it on the chat what you think it might be. So in June 2020, we had a 25-year-old male who attended the accident and emergency department at Salford Royal, and it was at the height of the COVID pandemic. And he presented into A&E with some bruising and bleeding. He tested negative for COVID and he had no previous medical history. And this means no previous medical history means he had nothing, no diabetes, nothing that would ever concern us. And he was a very fit young man. So we went on to do some investigations, and these investigations included a blood test, which, because we're haematology, we'll always do a blood test, and a blood film. So a blood film involves where we take a blood droplet of the blood test that we've taken, put it on a slide and have a look under the microscope what that blood film looks like. Now, if any of you have been fortunate to do work experience here, these are the things that we would show you and let you observe whilst you're here. Okay. And then we did a bone marrow. Now, the bone marrow is a blood test and a little bit of bone from the pelvic bone. And we sent that away to have a look at why this gentleman was so unwell. Anyway, he had a diagnosis of acute leukemia and he had intensive chemotherapy, which included a hospital stay of 4 to 6 weeks per cycle, and he had 3 cycles. And then he went on to have a bone marrow transplant. And he is doing very well today, and he's back doing everything he wanted to do. And he's been going go-karting, and he was a dancer, and he was a car salesman, and he's back working and very fit and well and doing very well today. That's sort of an example really of what we do here. And that's the more aggressive types of leukemias. We do lots of leukemias, but not as serious as that. Next slide, please. And this pre-pandemic, we was able to work in our environment without wearing a mask. And these are the pictures of an up to date, and this is what it looks like now working in a hospital to reduce the risk of infection. And it's changed, as I was saying previously, it's changed how we work and how we assess patients. Thank you, and any questions?
Sorry, we were just stopping it sharing then now, so hopefully everyone can see each other. Was there a question that came up there then? I think somebody put in. Yeah, Sienna Rose. So do people have to be referred to see you, Catherine? You're on mute, Catherine, sorry.
So what happens for patients who have a blood cancer? They either go to their GP, which is your general practitioner, because they are unwell with similar symptoms, but don't be frightened by what I've said, because some people can be just ill with coughs and colds and your usual feeling tired. So you either go to your GP, or you come to the A&E department, or you can be referred by another department in the hospital. And then when they come to see a haematology consultant, then we do some additional investigations so we can get a diagnosis for each patient. And then once we have a diagnosis, then the patient will be seen and treatment will be started. Now, this might not make sense to you now, but when you go to a GP and A&E, if they are suspicious of cancer, everything has to be done urgently, and it's called a 2-week wait, and it means that investigations have to be started very quickly.
Great. Does anybody else have any questions, or if you want to type any questions, because I know you're a bit shy sometimes in speaking out, you can just type them in the comments box, and then Catherine will try to answer them as best she can. I don't know if Kerry can do that with any of her students as well, if she can hear us still or not. One of the things I was going to ask you, Catherine, is obviously, like you said, it's leukemia, and we always hear of children a lot with leukemia type of cancer. Yeah. How do you deal emotionally with that? You know, is there certain skills you have to learn or training? Because, you know, I know it's hard telling anybody, but it must be harder when you've got parents and young children.
Yeah, so at Salford, we don't treat anybody younger than 24, okay? Anybody younger than 24 would either go to the Children's Hospital, or in between 16 to 24, they go to the Christie Hospital. Because it's a specialist role, we have additional courses of advanced communication skills. And we have regular clinical supervision and emotional support, where we discuss the case and what support is needed for us to be able to deal with this emotionally.
Great. I think we've got a few more questions coming in now. So I think Charlotte said, is leukemia the scientific name for blood cancer?
No, because blood cancer covers lymphomas, if anybody's heard of lymphomas, myelomas, which is a paraprotein in the blood. This is often confused with a melanoma, which is a skin cancer, because it's something that people haven't heard of. And myeloma is normally found in the elderly over 60. 60 is not elderly, I have to tell you that. But it is, but it is. So we do lymphomas, leukemias, and myelomas, and it all comes under an umbrella of a blood cancer. But we have, let me see, Olivia has put why do they call it acute, and what is the difference? So an acute leukemia, an acute setting, means it's something that happens very quickly. So if you have an acute leukemia that they may have been unwell for a couple of weeks, just felt very tired, had some bruising, maybe a bit of bleeding from your nose, your gums, but couldn't really put their finger on why they feel unwell. And then you would have a blood test, and that blood test will be able to tell us straight away. Now, an acute leukemia means it has happened very quickly, and will respond very well to chemotherapy, but will require quite urgent treatment. Okay. Now, the opposite to that would be your chronic leukemia, which is something, a blood cancer that's been grumbling along, and we may stumble across that by a routine blood test at your GP, or you may become unwell, but that means that you need treatment, but we've got time to do some additional investigations, and your treatment will be given just in a tablet form as an outpatient. Okay, whereas if you're an acute patient with leukemia, you need to stay in hospital for 4 to 6 weeks to have that treatment. Somebody's put, would you be able to go on this ward for a placement? So Emily, pre-COVID, I do take students once, a couple of times a year for a week, and have a plan for them where you can watch a bone marrow. You can have a look at, you can go to the ward, you come on the ward round with us, to the pharmacy. I'm not sure how things have changed with COVID, but I know that if we're starting to take students again, then we'll happily take students and organise exposure for anybody. And it's not for everybody that wants to do it. And it's not for everybody. I'm not saying it's so that you will be a nurse. It's a very good exposure for anybody who would be interested in medicine or working in a hospital environment.
I think there's a few more then. I think Charlotte said, can leukemia be genetic, and what causes it?
Right, leukemia is not genetic at all. There is no genetic link in leukemia. It's just something where what happens with any cancers is a cancer cell replicates in the body, and it makes more and more and more, and then it overtakes it. That's what happens with the leukemia in the bone marrow. So it replicates and makes more cells, but it isn't genetic in any way. It's just unfortunate that you get it. What is the lymphocytic part? What does that mean, Olivia?
You can unmute yourself, Olivia, if you want to ask.
Is it to do with the white blood cells? Right, so leukemia is to do with, so I don't know if you know, but your bone marrow is a factory for your blood. So it has the red cells in, the white cells and the platelets. Your red cells are the cells that give us our oxygen and energy for your red blood cells. The white cell count is the one that's responsible for our infections, and that fights infection. And the platelet count is the one that's responsible for our clotting. So when you cut yourself, your blood clots, and that's how it stops bleeding. Okay, the leukemia is a lot to do with the white cell count. So that it means that you start to have more infections that you don't get rid of. Okay, and that's when you become unwell, and you may present with a very, very high white cell count when you come and you get diagnosed with leukemia, but that is not always the case. What you have to remember with any cancer, even if I had the same diagnosis as the chap next door to me, we will both be different in how we present, how we respond to treatment, what our side effects of the treatment will be. So even though it's the same condition, it doesn't behave in the same way with each person. Hold on a minute, is it to do with this? Yeah, so we've got that white cell count diseases and infections. Yeah. What happens for you when you recover is we give the chemotherapy. So you present with a bone marrow full of leukemia cells. Okay. And then we give you the chemotherapy, and the aim of the chemotherapy is to kill all them leukemia cells. So at the end of that treatment, we do another bone marrow, and we see that we've killed all them cells, but we know that that one cycle of chemotherapy will not get rid of that leukemia for a very long time. So we give some more, and then depending on how you presented and what your risk is, determines whether you will need a bone marrow transplant or not. Okay, so some people have it and have chemotherapy, and that's the end of treatment. Other people need to have a bone marrow transplant because they presented as at high risk at the beginning. Okay.
I think there's a couple more questions about lymphoblastic part.
Right, okay. So, oh, I know what that one means, Olivia, now. Hannah, what do you do if you're allergic to platelets and you need a blood transfusion? So a blood transfusion, Hannah, and a platelet transfusion is completely different. So when you have a blood transfusion, we take two extra samples of you for a blood transfusion, and we send it to the blood bank and they match it up to your blood group. Okay. Now with platelets, so when you have a blood transfusion, the blood transfusion lasts a good few days or a little bit longer. But when you have a platelet transfusion, it only increments at that time and you may need another one. Now, sometimes if your platelet count doesn't increment, we send a special matching off for the platelets so that the platelets match you, because sometimes your body can change with too many transfusions and you stop responding to it. So they send off and we have special platelets then for you. Does that make sense to you? And then Olivia, lymphoblastic, I know what you mean now, Olivia. So there's two different types of acute leukemia. So you've got acute lymphoblastic leukemia and you've got acute myeloid leukemia. The acute lymphoblastic leukemia is what we see in a lot of children. And children do very, very well with an acute lymphoblastic leukemia. It's a similar pathway, similar presentation, different treatment, and with a similar outcome, but young children do very, very well with acute lymphoblastic leukemia. There's a very good cure. Platelets are part of the structure of the body, I'm pretty sure. Yes, they are. Platelets are. Yep. Can you become a bone marrow donor? Like you can become, yeah. So you can. There is the Anthony Nolan Trust. Is for anybody under the age of 40. So all you have to do is you can register with the Anthony Nolan Trust, and then they would do a blood test on you. And then if anybody needed a bone marrow transplant, when they need a bone marrow transplant, they have a blood test and it gets all does like a structure of matches on them. And if they found your blood test on the transplant list and you was a match for this patient, they would contact you to be a bone marrow transplant. Now, the way that works is it's done in a way that you have a blood test and then they match it up and then they would see you and then they would do some additional investigations to make sure that you're well enough and fit enough. And to be a bone marrow transplant donor, you have to be a 10 out of 10 match for that patient. But the other thing is, because we are in a multicultural society now, there is a national shortage of minority ethnicity groups donating. So for somebody like myself who's white Caucasian, I have got a quite high chance of getting a match from my donor. If you're from an ethnicity group, because there's not as many donors on the register, the percentage is less. If you need a donor, you would use your siblings first. They would test your siblings to see if your siblings were a match before they went to a donor register. Is AML more fatal than lymphoblastic then? Not necessarily. It depends again, because I don't really want to scare you here. You're in year 12. it depends. Everything that we do is dependent on how that patient responds to treatment. So irrelevant of your condition and whatever the statistics are or the percentages are, the key element of all of this is that you respond to the chemotherapy. Does that make sense to everybody?
Yeah, it does to us, definitely. Yeah, we said yeah.
Yeah, okay.
Does anybody else have any more questions before we let Catherine go? Anybody wants anything? I think you've asked some brilliant questions there.
I do. I wasn't sure if it was the right audience or it might be too much for them, but I think the questions that have come back have been very relevant, really.
They have, and quite probing and in depth as well about the subject. So I know Fiona and I are sat here and we've learned a lot as well. So definitely it's made us think about what we think about your role and how wide it is. So yeah, that's been really interesting, and I'm sure we're recording this, so any students who've missed it or haven't been able to come on, then they'll be able to listen in as well. It'll be uploaded onto Teams, and then they'll all be able to share it as well. So if any of the students missed any information, we will share it with you so that you can pick it up again. Thank you so much, Catherine, for taking out this time to present, because we know how crazy busy you are as well in your role. It has been really interesting, and we really appreciate you coming on to do this.
Okay, thank you.
Thank you very much.
Thank you, everyone. Good luck, everybody, with the studies. It feels hard, it feels tough, but it's all worth it.
Great, thank you for that prompt. All right, take care, everybody. Have a good afternoon.
Thank you. Thanks.
Bye.
Bye. Bye. Bye. Bye.